So moving on to the other portions, potential injuries of the lower extremity. Um, a lot of people come in complaining of pain in their shin, obviously very common in runners. And the big important thing to do is to make sure there's not a stress fracture of the tibia. There's a couple of things that we see in athletes in the leg. One of them is stress fracture, the other is shin splints. It's also called medial tibial stress syndrome, and they sort of have different patterns of presentation. People who have stress fractures typically have very point tenderness. It's not diffuse. People with shin splints tend to have more diffuse tenderness over a larger area of the bone, whereas stress fractures are pretty
And
tender.
MRIs will miss a lot of stress fractures, or they always catch them?
They catch them.
Okay, it's the X-ray where you miss it typically?
Almost, it's really hard. If you find a stress fracture, the first visit of somebody on a tibia, they've had it for a very long time. So we always get x-rays because sometimes there are other things in the bone that we need to make sure, not a tumor or infection or something that we're not expecting. But it's rarely positive on the x-ray for the first presentation. It's also, you have to get it, for most insurance companies, you need to get an x-ray in order to order an MRI. So those are two things: shin splints, or also called medial tibial stress syndrome, and stress fractures. Also, chronic exertional compartment syndrome. There's compartment syndrome is where there's increased pressure inside the compartments of the leg. There's an acute situation where we call acute compartment syndrome, which happens if you break the tibia. But there's also some people who run, and during the run, they start to get some swelling of the leg, and they even get some tingling and numbness, and it's because the muscles are in a very confined space. So as you exercise, the muscle gets fluid in it, hypertrophies, and people will develop those symptoms. So it's important to check all these areas. And also, we also see in the back of the leg gastroc injuries and Achilles tendon, but we'll be able to evaluate that more in the prone position. So if we start examining the foot, I've done a lot of inspection during the standing portion of the exam and have you walk, so I have a good sense of your arch. I often will start in the back here. In the posterior aspect of the ankle, the tendon that flexes the toe is in that region. Sometimes dancers will have tenderness and tendinitis of that tendon. And so we're palpating back there. As we move medial, you have ligaments that support the ankle. This is the deltoid ligament, and I'm checking the integrity of that ligament. Very important tendon called the posterior tibialis tendon, which runs right behind the medial malleolus. This is the medial malleolus, and it inserts down here, and that helps to invert the foot, right? So when you're doing a toe off, when you're walking, that has to engage so you get a rigid foot so you propel. That loosens as you go flat foot when you land, and that needs to soften. People who have injury to that tendon, very flat-footed, painful, swelling on the inside of the ankle, and that's the posterior tibialis tendon. And as we palpate along the top of the foot, you have the navicular bone and also the metatarsal. We check the range of motion of the metatarsal phalangeal joint, interphalangeal joint. Another injury runners get is they get arthritis of that first joint. So there's what we often hear about, or bunion or hallux valgus, where this starts to deviate in. And that can be painful, and the second toe can also translate to accommodate that movement. But another thing I see a lot in runners, some arthritis of this joint, and if I hyperextend, that hurts as well. At the bottom of the toe, there's also two bones called the sesamoid bones. People get stress fractures and irritation of that. And then we see acute injury in athletics where you actually can injure the ligaments on the bottom of that toe. It's turf toe, and sometimes that could be serious as well.
And they present how?
Severe swelling. It's very painful. A lot of swelling on the toe. That's not rarely one of those injuries where you're like, oh, and look what you have. It's really a really quite dramatic episode. But for sesamoiditis or stress fractures of the sesamoid bones, that sort of develops slowly and hurts on there. People with pads, they try to rest a little. They start to land on the outer part of their foot when they run, and that needs to be evaluated as well. As we move across sort of the top of the foot, you have the tibialis anterior, this is the tibialis muscle. This is the tendon.
And that's probably the most common discomfort I will get. And what's very odd is the speed with which it can come on. It's like I can be sitting at my desk doing nothing, having no pain, and I get up to go get a drink, and I have, like, there's someone putting a knife into there. And
So in those circumstances, sometimes it's hard to distinguish tibialis anterior tendinitis or inflammation from a process inside the joint, because the capsule of the joint is so closely associated. One thing we see a lot with what you talk about is that the tendon will squeak. It actually makes a noise when it gets inflamed. So people will come in and say, my tendon's squeaking. And that's usually right away we know that's the tibialis anterior. And we palpate the capsule too, and sometimes it's fuller than the other side. And so then we also range it. We want to see how far you dorsiflex and plantar flex. For motion purposes, we're checking also the subtalar joint. So just to review, you have the ankle joint and you have the subtalar joint. Subtalar joint is between the calcaneus and the talus. That joint is incredibly important for navigating terrain. If that's arthritic, some people even born what's called a coalition, where they're fused to each other. Constant ankle sprains because they can't navigate through terrain and they will easily twist their ankle.
Now, I sort of seem to have these naturally very high arches.
Right.
Does that go hand in hand with what seems to be quite a bit of laxity in my ankles and feet? Or is that just from swimming, where, you always have to be very, very, very toe pointed?
Yeah, there are certain things that are developmental as well. There are certain sort of things that you're born with. There's one condition called Charcot-Marie-Tooth disease, where people have this and they will sometimes get some weakness of the intrinsic muscles in the feet, and there'll be some preferential strength in some muscle groups over the other. And when we see someone with high arches and it's causing trouble, we will want to investigate those things. So that's something we would dive into deeper.
And my arches would be considered high?
Yeah, they would. And so also, some people have, we do this called the windlass mechanism, where when we put, because when you toe off, right, this is the first thing that happens, right? You sort of do that motion. This will help to tighten.
That's the eccentric loading in it to get ready to spring it.
And so this will lock the subtalar joint. It will make the foot rigid so you can propel. Imagine if you just had pronated feet and you couldn't do this.
Yeah, you'd have no spring.
That's right, and it would become very painful, and then you start to attenuate the tendon on the inside. So that's how we check the arch as well. And then we check these toes. We call these, unfortunately, the lesser toes. I don't know if you've heard that term, but this is the big toe and
the great toe,
and these are the lesser toes. And we're checking in between the web space to see if there's any tenderness. Sometimes that's a neuroma will be painful there. So also have to be mindful of stress fractures in the foot, especially in runners. The navicular stress fracture is a very serious high-risk stress fracture. The metatarsal, second metatarsal, third metatarsal, and we palpate all those. Let me scoot over a bit. We talk about the lateral. This is where a lot of injuries occur. And so, we check motion, right? And we're just going to see how much motion you have. And sometimes that's because of laxity here. And because you have high arches, you're more likely to have ankle sprains. So this is a circumstance where we would want to palpate the ligament. There's the ATFL, anterior talofibular ligament, the calcaneofibular ligament, posterior talofibular ligament. Those three ligaments are the main ligaments that support the ankle. On the lateral side, there's also a ligament that connects the fibula here, the distal tib-fib joint. And sometimes that gets injured, and that's what we would refer to as a high ankle sprain.
So when a person sprains their ankle when they're 15 years old, do those ligaments permanently elongate such that there's lasting instability?
Yeah, so there is, for the majority of patients who've had an ankle sprain, the majority go on are fine. They're probably a little lax, but they don't have any clinical repercussions of that. But there's a number of people who have recurrent ankle sprains because when an ankle sprain is a tear. It's a tear of a ligament, and it has to heal. And sometimes it heals Sometimes that ligament, when it heals, can cause pain because it just doesn't heal perfectly. So there's pain related to that healing ligament. Sometimes that ligament is looser and will cause chronic instability where they have recurrent ankle sprains or they just feel very unstable at the ankle. One of the important principles is to make sure that you strengthen the muscles on the outside. These are called the peroneal tendons, and they go around the back of the lateral malleolus here, and they help to dynamically stabilize the ankle. So the ligaments are static stabilizers and the tendon is a dynamic stabilizer. So anybody who's sprained the ligament will, we prescribe physical therapy to make sure those muscles are as strong as possible.
And the best physical therapy is sort of like an external rotation?
Yes, and balance training because I often have people, because they don't want to go to therapy and they say, let me do it, I could do it on my own, I'll just give me some exercises. And I'll show them exercises to do and I have them come back and then I put them through some balance tests and they have a horrible time. You need a balance board. I think you have an interesting device for balance purposes. That would be something great for that. And that's important so that we don't have to have recurring ankle sprains to get those tendons strong. Those tendons also sometimes when you have lateral ankle injuries, you can tear the connective tissue that keeps the tendon in the groove, and the tendon in certain motions will subluxate out of the groove and snap. So, just like the test with the hip where we do the circumduction, patients will come in and they'll show you. They'll do this, they'll circumduct the ankle and it will flip in and out. That's also missed often too. People have ankle sprain, it's swollen, it hurts, and they're not necessarily checking for that problem, and you have to be diligent about making sure you evaluate that as well. This is another sort of functional test to see the tightness of the calf. So the calf is basically your gastroc and your soleus. When your knee is in this 90-degree position, the gastroc is relaxed. And so when you do an ankle dorsiflexion, you may get excellent motion, and you want to make sure that you're bringing it straight up and you're checking the tightness of your soleus. But then we extend your knee fully and we do it again to see if we get the same amount of excursion.
And if not, it's the gastroc.
It's the gastroc that's tight. Correct. Okay.
So Achilles,
prone position. So very common to someone to come in and they have a rupture or they feel something sharp in the back of their calf. They felt a pop. It's almost as someone kicked them in the back of the leg. And what I'm looking for is whether or not the Achilles tendon is intact. And when Achilles tendon is intact, you see this nice contour of the tendon. It's not swollen. Oftentimes, or most times, if it's ruptured, you will feel a defect if it's an acute situation. There's something called the Thompson squeeze test, and if I squeeze the calf, the foot should go forward. It's also important to check the other side to see that the attitude of the foot is equal. Someone who has a complete rupture, their foot will be like this, and you know right away. It's not a very hard diagnosis to make in an acute Achilles tendon rupture unless you don't look. Most actually injuries in the calf or the back of the leg is an injury right where the medial gastroc muscle becomes the tendon. So muscle tendon unit attaches here. This is a weak spot where the muscle attaches to the tendon, and we call this tennis leg, and it's fairly common, and also people will feel that pop in that area. And that's it.